Okay, I guess in the interest of time, let's get started. Welcome everyone to Pediatric Grand Rounds. I'm Dr. Gayatri Jayashankar, one of the general pediatricians with ETSU, and I'm very excited to introduce to you Dr. Jennifer Jaynes, who is one of our awesome chief residents this year. Dr. Jaynes has been here 3 years with us doing her pediatric residency, prior to which she did her medical training at LMU, also within the area. We are very happy for Dr. Jaynes that she's headed out of here, going to do a pediatric emergency medicine fellowship, very well-deserved fellowship in Vanderbilt, and hope that we will see her back in the area following that, and her completing her training. During her time here, like I said, Dr. Jaynes has been one of our awesome chief residents, has taken the lead with a lot of quality improvement projects, patient advocacy projects, and has been very involved with all parts of the residency program. She has several presentations at a regional and a national level, as well as a quality improvement project from the NICU, specifically looking at optimization of care for the premature newborns within the first few hours of life. I'm excited to hear her topic today on toxicology. Dr. Jaynes.
Thank you. All right, so you guys in the back, let me know if you can't hear me, but I think it should be okay. So today we're going to look at sort of some new things that have happened in the study of pediatric toxicology, and take a look at some of the new things that the kids are doing these days. So the objectives for this talk, kind of general. Basically, we're going to look at some of the most recently published national data about some of the most common types of intentional overdoses and ingestions in our pediatric population. We're going to look at how they present and how you initially are going to take care of these. And then we're going to look at a couple of newer substances that we've seen sort of come into our region and nationally as well, sort of how they present and how you also begin to treat those. And then we're going to look at, basically because I didn't want to leave our outpatient colleagues out, I want to look at some of the potential strategies for prevention and anticipatory guidance that we can bring in to that to hopefully see these numbers decrease a little bit over the next couple of years. So I have nothing to disclose. And we'll start with taking a look at some of the things that we know from some of the most recent studies. This one is a little bit older of a study, but this was a study that was published in 2002, and it studied self-poisonings in adolescents to see if there were any characteristics that could be found that these patients all might have in common. And what they found, basically, they looked at 324 particular patients in the adolescent population between 12 and 18 years of age. And they found that most of these attempts occurred in females, and they were mostly middle to high school range. And an awful lot of them had certain concerning symptoms for depressive disorders, whether that be sort of not feeling happy or not wanting to have interest in doing anything, not wanting to hang out with friends, not having friends, those different characteristics. But a large majority of this patient cohort had those symptoms expressed. Also, one thing they noted was that a lot of these symptoms were in the context of family dysfunction. So as you'll know, that is not an uncommon thing that we see in our patient population. Now, the study didn't directly delineate any specific types of family dysfunction, but it would include things like parent in jail, sibling in jail, not having a parent, or not having a consistent parent figure, or those kinds of things. And then another statistic that I found, 2014 is kind of the most recent annual statistics that have been published, but the DEA reported that approximately 3.5 million teens have used illicit drugs. However, that sounds like a lot, but it's actually a 15% decrease from the previous year's reports. There are various reasons for this, and we'll kind of get into that in a little bit. So you'll see on this table, this is one of the tables that's been published in the American Association of Poison Control Centers annual report from 2014 as well. And this is information that's gathered by all the calls that they receive. All the state organizations kind of compile their data, and they put out this annual report every year. And what you'll see is the age distribution on this slide of the calls, and it takes into account on this one particularly the intentional and unintentional exposures. So as you'll see, about 14% of these were from the age range that we're going to focus on today, that range between 6 and 19 years. This is another chart from that particular report. And I put this in basically to show that analgesics were the top 3 causes for all ages. It's interesting, if you really take a look at this chart, you'll notice there's an age gap that's missing from about the 5 years to 19, which is kind of that age range we're looking at. The other interesting part of this particular report is while they have this categorized out, even in the text portion, which is about a 60-page report, they don't really delineate those categories of substance for that age group. But what they do have is a chart of the intentional versus unintentional based on age. And you'll see the yellow numbers I've highlighted kind of particular importance. And this is the number of intentional exposures or ingestions in the 6 to 12-year-old range, which was 11,390, and then in the 13 to 19-year-old range, which was over 92,000. So you'll see in that teenage years, the intentionals are the most common type of exposure that you're going to have calls to the poison control centers for. Again, another chart from this particular report. This is the most common route of exposures for all calls were ingestions, as we talked about. And you'll see this is mostly unintentional ingestions, but you have to take into account that less than 5-year-old age range that are the kids that get into things around the house. And as we saw the number from the age groups on the previous slide, we'll be talking about a little bit older group. So why is it important for us to discuss these things? So these are some pretty interesting statistics. And if the facts from the annual data from the poison control centers weren't enough to concern you, between 2000 and 2009, the CDC reported a 91% increase in drug poisoning deaths among the teenage ages 15 to 19 years old. So while potentially the amount of teenagers that are using illicit drugs may have decreased per the DEA, the drug poisoning deaths are going up. Another fun fact for you, drug-induced deaths now outnumber gunshot deaths in America. So those are very concerning pieces of data that make it very important for us to discuss these, even in our pediatrics department. So now we're going to talk about a couple of specific substances that are probably the most common that we as residents and pediatric providers are going to see in our hospital or emergency departments. And the first one, obviously the most common, is probably acetaminophen ingestion. So they have been sort of the mainstay at the top of the list for ingestions for adults and pediatrics for many years. But I think, at least anecdotally from speaking to several residents and doing research for this talk, I feel like we've seen an increase in admissions for acetaminophen ingestions in our hospital this year as compared to the last couple years that I've been a resident here. So why is it one of the most common substances for ingestions for pediatrics? Well, it's widely available over the counter, so anyone can buy it at any time. It comes in specific children's preparations, so there are liquid forms. They come in brightly colored bottles and packages, and it's one of the most common substances found in the home. Most people have different varieties of acetaminophen or other sort of pain relief medications. So it's very easy access is kind of the bottom line for this, and that's why we see it a lot. So just to talk about the actual medication itself for a minute, why is it so toxic when it's taken in large quantities? So it's rapidly absorbed as soon as you ingest it, basically, and it reaches its peak plasma levels in about an hour. So what this does is it causes the liver, where the acetaminophen is metabolized, to be flooded, and the glutathione stores, which is how the acetaminophen gets removed, to be flooded, and it shuts down the removal process and slows it down significantly. So that causes toxic metabolites to accumulate, and what you'll see is the subsequent organ damage that we're going to talk about. So now that you know how it becomes toxic to our body, how much can you take before it gets to be a toxic amount? So the literature on this varies a little bit. There are different sort of ranges, but in general, the minimum toxic dose for a pediatric patient is about 150 to 200 milligrams per kilogram. For an adolescent, this would be about 7.5 grams in one acute dose. There are some different ranges for sort of chronic toxicity that we don't typically see in our pediatric population very much, but for adolescents, it would be about 4 grams a day for at least 2 days. If they were going to get chronic toxicity. Most of that is from the adult population when somebody's taking too much for a particular problem and don't realize it's too much, take it for a couple of days, and that's when you see that. So we're kind of focusing more on the acute intoxication. So what do you see when you have acetaminophen toxicity or overdose? Initially, you're going to see mainly GI symptoms. You take a bunch of pills or you swallow a bunch of liquid. You're going to get a lot of the GI symptoms as some of the first things that you'll see. That's nausea and vomiting. This can last for the first 24 hours even before you'll see too much else. But over the next subsequent 24 hours, often the most common complaint is right upper quadrant pain. And then that's when you'll really see any lab evidence start to be elevated as far as your organ function. The most dangerous period of acetaminophen toxicity occurs after about the 48-hour window, and that's when you really see sort of the hepatic failure portion take place. That's when you're going to have not only your LFTs are going to be elevated, but you're also going to get problems with your coagulation factors, and you'll see prolonged PT and PTT. And this is what we're trying to prevent from actually seeing in these patients. As I was doing some research for this, I came across one of the research studies that I looked at basically said, remember, the damage is being done when there are no symptoms. So we want to try to catch them as early as possible. So the acute management, you'll notice this slide comes up several times. As with all ingestions and all acute events in general, you want to make sure their airway is secure. That becomes a little bit more important with a couple of the other substances that we talk about. But you will, obviously, if you have the GI symptoms when this patient presents, you're going to want to make sure they can protect their airway as they're having sort of the nausea and vomiting piece of it. For ingestions, there's a little bit of a standardized workup, if you will, that includes sort of, because again, sometimes they're not going to come in and tell you, I took this or I did this. Oftentimes they'll present with just lethargy or some sort of altered mental status, and you have to figure out what's going on. Teenagers don't necessarily say, I did this, help me kind of thing. So it's important to check blood counts. Is it an infection that's causing their altered mental status or the vomiting? Electrolytes, obviously, the complete panel will give you the liver function, so that's always good to have just in case it is some kind of intoxication. You want to make sure those are looking okay at the time you see them. A urinalysis is important along with a UDS, but specifically for acetaminophen toxicity, it can sort of give you any sort of early evidence of acute tubular necrosis. A pregnancy level is extremely important, and I feel like our emergency department, and even when they come from other hospitals to our floor, we're really good about ensuring that that gets done, because that kind of can change your approach a little bit if that is also a factor in the treatment. For acetaminophen, you want to get an acetaminophen level along with an aspirin, an alcohol level, and just to sort of see where they are. Ideally, we like these at the 4-hour window. Again, you don't always know the time of ingestion, so getting one when you see them is great. If you know the time of ingestion, it's really important that that 4-hour one is done. What else can we do? Well, poison control will become your best friend, especially for maybe our first-year residents who haven't seen much of this in the PICU. We talk to poison control a lot. Our folks in the emergency department tend to call poison control for every suspected ingestion or known ingestion that comes in, and we tend to do the same. And the reason we do this is they can help us work through sort of the presentation of the patient and the best options for management. They have protocols that they can treat. They have a protocol for acetaminophen toxicity that we've often had them send to us, especially early on when we hadn't had a bunch influx of these for us. So they sent us their protocol for the treatment, but also they manage the data. So they take these numbers of these patients we're calling, and that gets collected to make those annual reports that we were talking about earlier. So it's important to kind of let them know what's going on in our area so they can help track these trends. So something else we can do, if we know that the ingestion was less than an hour prior to arrival to the emergency department, we can give activated charcoal. And basically that kind of just absorbs what's left in the GI tract of the undigested pills or liquids or whatever that is. Often we don't really do this because we miss that hour window of opportunity for various reasons. The patient waits 2 hours to tell their parents they took this, or to tell their friends they took this, or they live really far away, or any number of things. So often we don't actually get this time window. But this is the dosing that you would use based on the age. So it starts at about 10 grams for the younger ones, and then goes up to 100 grams as the max dose one time. But you have to remember that activated charcoal can't be used for all ingestions, and it's not effective for ethanol, methanol, iron, or alkali poisonings at all. So what else we can do? This little graph has become a good friend of ours. Again, as we're seeing more of this, we've referred back to the Rumack-Matthew nomogram that assesses the risk of hepatotoxicity based on the acetaminophen level that you get. Again, the level sooner than 4 hours is not necessarily helpful because it doesn't really predict the future rise or fall of the level. So I'll show you the graph actually in just a minute. But if it's above the line that says likely hepatotoxicity, then we use N-acetylcysteine. We tend to use the IV here, and we'll talk about that in a second. But this is the dose. You'll see it's kind of a 3-bag system that you get over the course of about 21 to 24 hours. And while you're getting that, it's nice to follow the liver function tests and coags. So you can kind of see what the trend is. They say it's not necessarily important to follow the acetaminophen levels because you're treating it, but the actual liver function and signs of organ damage are going to be the things you want to see. So here's the nomogram. This nomogram has been around since the 70s. That's when the first paper was published. And it plots the acetaminophen plasma levels and then the hours post-ingestion. And the top red line was the initial line published that says this is the toxicity line, and above this you treat, below this you don't. But the FDA actually required the authors to add the lower line, giving a 25% range in between the two lines for possible toxicity, and that's because they wanted to account for any differences in labs. So various lab companies, draws, some of the ranges are a little bit different, so they wanted to kind of account for that. So that's why you'll see now there are two lines. And then the dotted line that's vertical there, you can kind of see that's the 4-hour level. That is really the one you want to look at as far as basing your treatment decisions on. Now we also do sometimes choose to treat patients with unknown times of ingestion that are likely within the last 8 hours or some kind of weird stuff like that in the levels. We can look at this chart and kind of see, yeah, it's a little bit questionable, so sometimes we'll treat those too. But the 4-hour one is really kind of, if you can do that reliably, that's the one you want to really look at. So N-acetylcysteine, how does it work? Basically, your intestines convert it to cysteine, and cysteine is a very important substance that helps to replenish those glutathione stores in the liver. So that helps to remove the toxic metabolites a little bit more quickly. There are some side effects. Obviously, the most serious one and the one that everybody kind of worries about is this anaphylactoid type reaction that's not IgE mediated. And it's not super common, but that's one of the things that you'll hear about the most if you ask anybody about N-acetylcysteine. But that doesn't necessarily mean that if the patient has sort of these symptoms develop during the infusion that you should stop it altogether. You hold it, and then you symptomatically treat them for this with antihistamines and albuterol and epinephrine if needed, and then you resume the infusion because it's very important that they get this medication as far as from their liver standpoint. There is a PO form of the N-acetylcysteine, and the studies that I have read said the efficacy is actually equivalent between the forms. We don't tend to do the PO form because most of the time these kids are vomiting or nauseous or feeling like they're going to start vomiting, and so you can't reliably ensure that they're going to be able to keep it down enough to actually see an effect from the medication, so we tend to prefer to do the IV form. So now we'll talk about another one. I've just picked a couple of the most commons because these are the more high-yield substances, and we'll talk about diphenhydramine next. Why is it one of the most common ones? Again, it's readily available over the counter. It comes in children's forms, it comes in adult forms, again, it's in liquids and all kinds of things. Not only that, you can get them in combination medicines for allergies, for cough and cold medicines, for sore throats. They even have it in combination with like viscous lidocaine and things for patients who want to be treated for like ulcers in the mouth. So it even comes in those kind of preparations as well. So it's very easy access. So like I said, it is an antihistamine, but its main problem is it does have anticholinergic properties. So this explains a lot of the symptoms that you'll get with the overdose. There's a lot of literature that I found that's kind of debating these anticholinergic effects being dose dependent. So again, with the significant ingestions, you're likely going to see these. And some of these symptoms, I've just put some of the signs here, but everybody remembers the mnemonic for the anticholinergic poisoning, so the blind as a bat, hot as a hare, that kind of thing. But really it can get pretty serious with respiratory failure. They have urinary retention, and they have a lot of neurologic and psychologic issues. So again, this person is probably going to come in with altered mental status, and you have to figure out why. So it definitely can look like other things. So it's important to kind of think about the whole realm of possibilities. Again, the workup, pretty similar and standard, like I said. But again, a blood culture might be something that's important because they're usually febrile, they usually have altered mental status, they can have agitation, and so if that occurs or they've been, passed out in their house for a long time or those kind of things, it's sometimes important to add a CK so you can assess for any rhabdomyolysis that might have occurred. Management, again, you want to protect the airway because of the respiratory failure and degree of CNS depression. These patients often need intubation when they come in, and if not, they need elective intubation because they tend to get worse pretty quickly. And then you want a good IV line for hydration and other things if you need it. So there is an antidote, and we'll talk about that for a minute. So physostigmine is an acetylcholinesterase inhibitor that you can use because it crosses the blood-brain barrier. So it can help some of the CNS effects of anticholinergic intoxication. This is the dose range you see here. I think most people use about 0.02 milligrams per kilogram, but the max total dose for the pediatric population is 2 milligrams. You shouldn't use it with everybody, though, because there are pretty serious side effects with it. So we typically limit these to severe cases with significant hemodynamic compromise, patients who have recurrent seizures that they can't get under control, or such significant agitation that it's a threat to the patient or surrounding people. But in this case, poison control should always be aware of the patient and your plan if you're considering the use of physostigmine. And you should always have atropine available at bedside because the administration of this, that if it happens too quickly, it can cause profound bradycardia and can actually lead to arrest type situations. And you actually cannot use these in patients who have documented conduction abnormalities on an EKG. So you will get an EKG on these people when they come in. That was on the previous slide. But if they have prolonged PR or QRS intervals, or even QT intervals, you're not going to want to use this at all. And at that point, it just becomes symptomatic and supportive care. So now that we've talked about some substances that everybody knows, we'll talk about a couple that are out there in the region and nationally that we should be aware of and suspicious about, and then how they present, because often they'll come to the office, they'll come to the emergency department, they'll be at school, they'll come home, so things that you can tell parents even to look for. So we'll talk about this class of substances, the cathinones. They're newer. Essentially, they are amphetamine-like products. They're man-made products that are chemically related to the cat plant, and that's a picture of it there, that grows in Africa and Arabia, and they use it there quite a bit. But these products are man-made, so they're synthetic, and they act similar to it, but they're a little bit more dangerous. Of note, this plant is illegal in the United States. So we'll talk about their appeal. The clinical picture in general represents a state of what they call excited delirium. So unlike amphetamines, their metabolites do not get picked up on a routine urine drug screen that we do. So they're hard to detect, and they're extremely cheap. So they're cheaper than the other amphetamines that you can buy out there. They're about $3 to $5 per use. So that's incredibly affordable to the pediatric population. So that's one of the draws to them. One of the most commonly seen ones in this class of medications is bath salts, but we'll talk about another one that's related as well. So I know everyone has heard about bath salts. That made its way into our region a few years ago. And nationally, it was on the news. Poison Control put out an actual alert for it to kind of introduce everybody to it when it first came out. They're in no way related to actual bath salts, so that is some confusion in the lay population. But what you'll get, these are the signs and symptoms that you'll get. Again, it's that state of excited delirium. You have tachycardia, you have decreased inhibitions, so they do crazy things for no reason. But they also can have agitation, like significant paranoia and hallucinations. And these can be any types of hallucinations. They can be auditory, they can be visual, they can be tactile. So it could be any number of things that they will actually come in looking like. But again, they're going to present like altered mental status. So definitely want to keep this in the back of your mind. This is another one of the newer ones. Alpha PVP is sort of the medical abbreviation for it. You'll see the actual name there. I'm not going to try to pronounce it, but it's actually been around since the 1950s and 60s. However, there's been an increase in synthetic production of this particular substance in the last 3 to 4 years, and it's all being brought in from China is kind of where they've pinpointed it. These are some of the names that you'll see it go by. Gravel is what the people around this region tend to call it. But it goes by Flocka is the other name for it. It's been, the highest rates of usage have actually been seen in Florida, and that's where a lot of our, the people who are getting caught with possession of this have been getting it. And so you'll hear it called that as well. So it comes in an actual light-colored crystal that smells terrible. You would think that that might be a deterrent, but apparently not. You can eat it, you can smoke it. You can also actually liquefy it and put it in e-cigarettes, so that's been a really big increase in usage ability there. They'll just put it in there and actually use the e-cigarette just like any other liquid that's put in it, or it can be injected. So the injected forms and the snorted forms tend to be the most severe reactions that you'll get from it, again, like any of the other drugs that we've seen. But again, you can eat it, so any different number of ways they can get to it, they can. So we've seen it in the past year or two, maybe the past 3 when I first heard about it. But these are just a couple of headlines from our local news area that proves that it's kind of not really going away. And then it's made its way into the teenage population. So definitely not something that we're going to be escaped from thinking about. And I actually had a patient on one of my PICU months, I think it was the last month I did PICU, that was admitted. He told us he took something, but he didn't tell us what it was, and he presented just, again, like I said, he was in this delirious state, hallucinating, and in our conversations with Poison Control, they said this actually might be that. Again, there was nothing on the immediate drug screens that we could tell, but his amphetamine did come back negative, so it did make it something a little different, more likely. So the alpha PVP clinical picture, very similar to the bath salts, but this was a quote out of one of those news articles, and I thought that summed it up a little bit better than a list of symptoms. But it says, basically, you're dealing with a bunch of zombies, so completely out of their mind. And I looked up a bunch of videos to try to put a video on this presentation to show you a little bit of what it looked like. Look at those on YouTube yourself. A lot of them have a lot of inappropriate language or things like that associated with them, so I didn't want to bring that in today. But it's very interesting. They have, not only are they hallucinating and delirious, but they have a lot of like dystonic, writhing type movements. They get on the ground and roll around and do a lot of crazy things. And it is potentially a very scary situation. So, like with the other ingestions, this kind of basic workup is going to be good for you. Troponins are really good to add, again, as this cocaine or some other sort of amphetamine that can cause acute cardiac injury. So it might be good to think about adding those in with this. There is a chemical substance called MDPV that's commonly picked up on the UDS of a bath salt ingestion. However, not all actual labs will test for it. I don't think our urine test actually tests for those substances. But in the regions of the country that really have a significant problem with this, they've added it to it just to help detect that, also to track data for that. Again, like I said, you must consider other diagnoses when these people present. It can be very encephalopathic looking. Are they septic? So you have to kind of approach it from several different angles, but you want to keep this in the back of your mind, and that's kind of the point of us talking about it. So often elective intubation is good for these types of patients because they're going to be very combative and agitated, and you're not necessarily going to get a bunch of stuff accomplished with them easily. So they're going to need an IV. You can control the aggression and the agitation. Benzodiazepines tend to be what the literature recommends getting the best results from, but again, it might be best if they are intubated for these types of treatments. Because these people often come in severely dehydrated because they're out of their mind and crazy, and who knows, this can last for hours to even a day. So most of the time they're not going to just remember, I need to eat or drink or do those sorts of things. So they can come in with such severe dehydration that they can have renal failure. They can have rhabdo as well. So it's important to follow their kidney function closely because some of them have actually needed dialysis. So again, it can take up to 72 hours to fully see these symptoms from these ingestions, these particular class of medications dissipate. So now we'll talk about another one that's not necessarily as new, but we're really seeing a lot of it in the pediatric population more because the access to it is a little bit more widely spread now. So synthetic marijuana, there are tons of other names. There was probably 10 other names when I was looking this up that I'd never heard of, but that this particular substance goes by. I think K2 and spice tends to be the most common. And you'll see there on the right of the screen, the picture is a picture from the DEA. And this depicts kind of how these things are packaged now. They're shiny, they're colorful, they're all appealing to people. They don't look dangerous at all. It looks like something somebody's going to want to buy. So it can be very appealing to the teenage and older kid population. The actual substance itself is chemically similar to THC, so the substance in marijuana. But typically these substances are laced with other things via spraying of their plants or additives later after sort of packaging or as packaging is being done. We have no idea the breadth of things that they can lace these substances with. Opioids are a really common additive to this after the fact, but it can be pretty much anything. Heroin, cocaine, it can be anything they can find to put in. It could be not even any sort of drug. It could be whatever they can find. So it gets to be a little bit tricky for us. Because of that, we don't know all the components of it. It makes it difficult to predict the course, to detect in drug screens, and for us to treat. So this is a graph from the Poison Control Center's report that specifically looks at the synthetic marijuana compounds. And this shows the number of calls in the past 6 years. So you'll see the very bottom line, the shortest line, that's this year's. So it starts in January, and we have up to about April of data for this. You can see it's about 250 calls to 300 calls for this year. But again, this is something that may look like, according to this graph, it's not necessarily being a big problem. But you'll notice sort of the peaks for these uses are the summertime months where kids are out of school, they need something to do. And so I suspect we're going to see, as we follow this trend out, kind of the same way as the last couple of years have gone.
Look at last year.
The big orange line is last year. So that was an average of about 1,500 calls in the month of April last year. For some particular reason, it did drop off, but that's a scary jump for us. So these products, how are they used? Usually the dried plants are smoked. However, they can be brewed in the form of a tea and actually drank. So that's a little scary as well. And then again, there are newer forms that are liquefied, and you can put them in e-cigarettes and smoke them that way. So the clinical presentation is a little bit nonspecific and looks like a lot of other things. But you'll notice that these kids will get some sort of psychosis and hallucinations, but they don't tend to be aggressive. So they have some mild agitation, but they're not the people that are kind of like trying to get out of the place and do things like that and hurt people or, that kind of stuff. So, but you have to remember that these products are laced with things often. So if you have some that are laced with other amphetamines or PCP, for example, they're going to be much more aggressive and agitated. So you want to be aware of that and wary of that as well as you're treating them. So the labs, again, very similar to what we've talked about. Cardiac markers are going to be pretty important for this too, because again, they get laced with a lot of different things. Your UDS is going to be negative because it's not exactly the THC compound. You may get positives on other things if they're combined with other things. So you should look for co-ingestions as well, including Tylenol, aspirin, and alcohol. The treatment for this is largely supportive. There's no specific antidote, but again, opioids are a common additive to this. So naloxone is a good thing to consider when these people come in, and that's the dose there for the pediatric population. You can repeat the dose, and sometimes they even end up needing to be on an infusion of naloxone. I had a 2-year-old that came in as an accidental ingestion. One PICU day I was on call, and the mom had used some synthetic marijuana and had passed out in her house, and she had just left things scattered about, so the kid got into some and ate some. And family found him kind of unresponsive with all the papers and the actual synthetic marijuana scattered around him and around his face and whatever. So he came in with pretty significant respiratory depression, but responded really well to naloxone, and ended up on an infusion of that for 4 hours or so before he became much more alert. So these things are out there in our community, and again, it's very dangerous because we don't actually know what all is in it. Cardiovascular support is important. They can get pretty tachycardic, so beta blockers are some things to consider. And if they do get significant agitation, you can do benzodiazepines, and that's if your airway is secure. If they have opioids and you use naloxone, sometimes that can send them into seizures, and so benzos would be the treatment for that as well. All right, so now that I've kind of given you an introduction to some of the different medications, we'll talk about some of the things that we can do in the outpatient setting, at home, at school, to kind of make an impact on the preventative side. And this is a diagram that came out of a Peds in Review article. And it shows kind of the progression of substance use during adolescence. And you can see you start right here on the left side with abstinence. So that's pretty much nothing. These kids haven't tried anything, haven't heard about a lot of stuff. And then something happens for whatever reason, and they try some kind of substance, alcohol, whether it's at home, at school. And that becomes what they call the experimental use. Well, if they continue to use that over time, they get what the authors of this have called non-problematic use. I'm not really sure about calling it non-problematic use because I think in our population any use is problematic. But what the authors have described is experimental use repeatedly without any negative consequences. So they haven't been caught, they haven't been driving and had an accident and killed somebody or hurt themselves or any of those things. When they either repeatedly use this enough or they've been caught by their parents and continue to use or the school, then that becomes what they call problematic use. Continued use leads to abuse, which leads to dependence. And it's important to note that people can recover from these things just like in adults, but we really want to get them sort of in between this abstinence and experimental use part if we can, and kind of hopefully prevent the other progression from happening. So, how do we address it in an outpatient setting? So we make screening for drug use behaviors part of our well-child checks. It's good to be comfortable with it in the outpatient setting. I know the residents have all gotten significant experience with this when we do our adolescent rotations with Dr. Chastain, but really we should be discussing these things even earlier in that 10, 11, 12-year-old population that's getting ready to go into middle school or just got into middle school, because again, middle school is where we're seeing a lot of this happen too. So we really should be discussing it even earlier than that. So the best way to approach it in a visit setting, obviously you want them to feel as comfortable as possible telling you things, so you don't necessarily want the parent in the room. So you want to kind of nicely ask them to leave for a couple of minutes, and then you want to talk to the patient about the kind of things that you're going to be asking them. Give them sort of a heads up. We're going to talk about some things that might be uncomfortable to talk about. Remind them that it's confidential information, except in the instances of harm to themselves or somebody else. So you want to be very upfront with that, and most of the time they're going to respond to that. We do this in the hospital as well for pretty much all of our adolescent population that gets admitted for pretty much anything. We do a pretty good screening of risky behaviors. So you guys will recognize this mnemonic, the HEADS questionnaire. This is kind of how we're taught in medical school, and even in residency to some extent, to sort of organize these types of questions to make sure we hit all the good things that we want to ask. There are tons of variations on this, but this is kind of the basic one I think that's pretty standard universally. So the H stands for home life, so you want to talk about, do they get along with their parents? Do they have parents that are there for them? Do they feel safe in their home? E is for education, or if they have a job, it stands for employment. How are their grades? Are there anything going on at school that's concerning? Are they being bullied like crazy? That's something that we really have to worry about these days. And A is activities, so are they involved in anything? So you can really kind of see how you can get some red flags for maybe some of those depressive symptoms we were talking about earlier by just asking these questions. If they don't have any activities, they don't have friends, they don't have families, their grades are terrible, this might be something that will light those things up for you. D is drug use. So you want to ask them in a non-threatening way. You don't want to say, do you do drugs? That isn't the most helpful way to approach it, but you want to be very specific. So you just tell them that you know things are going to be around, able for them to have access to, and you just kind of want to gauge where they are with that. And then S is sexuality. Are they sexually active? Are they utilizing safe practices? That kind of stuff. And then there's another S that stands for suicide or depressive symptoms. So you want to kind of talk about, have they had attempts where they wanted to harm themselves? Have they had a plan to harm themselves or somebody else, or those kind of things? And you can do this in a minute and a half. So it's a long list, but you can do it while you're even examining them for some things, like how your grades are at school or that kind of stuff. So this next slide is the CRAFT screening test. And this is something that was published in the same Pediatrics in Review article that had the diagram. It's very similar to the CAGE questionnaire. You guys might remember in adult medicine there's a CAGE questionnaire to assess for risk for alcohol abuse. But basically, this one particularly asks, in the last 12 months, have you ridden with someone or driven someone who was high or been using alcohol or drugs? Do you ever use them to relax or feel better about yourself? Do you use them when you're alone and nobody's around? Do you ever forget things that you did while using these substances? And then do you have people in your life that tell you that you should not use them or use them less frequently or those kind of things? And then have you ever gotten into trouble? So this will get you to that sort of problematic to non-problematic use type of part in the diagram. And if you get 2 or more things that are yes, they constitute that as a positive screen, and that needs some additional questioning and assessment at that point. So we've talked about what to ask the kids, but there are things that we can tell the parents as well. So we really want them, we give anticipatory guidance to the parents during all the well checks, so this just becomes part of it. So you really want them to be actively involved in their children's lives, know who they're hanging out with, where they're going when they're hanging out, and probably most importantly in the last couple years is what they're doing online. So social media has become an awful ability to have secrets, to hide things, to become friends with people they don't even know, or to meet people that they don't even know, and anybody can say they're anybody online. So it's very important that the parents are keeping on top of this, or whoever the guardian parent figure is in the family. So there are drug dealers who are friending people on Facebook just to gain the trust of a teenager or a kid, and then saying, hey, let's meeting up, and that's where a lot of the problems can start to happen. So there have been lots of reports of that in the news nationally, so it's definitely something that's prevalent. And then you want them to talk to their kids about the dangers of medications in general, especially even over-the-counter, because as you saw, some of the most common things that we're seeing are the over-the-counter medicines because of the accessibility. And then for them to really look at the behavioral changes in their kids. Sometimes that happens in the teenage years and it's normal teenage behavior, but there are subtle changes that people will say when they look back on it, they really should have seen it, or it should have triggered something in their mind to think about. So that's just a little bit of advice for the parents that we can do. So just a couple of conclusions that I have kind of from this presentation. From the numbers, it looks like that pediatric drug use overall may have decreased slightly in the last couple of years, but the actual intentional ingestion rate is increasing. And I think our hospital admissions, whether that be for medical clearance or just for placement holds for psychiatric facilities, are reflecting this point. There are new synthetic drugs constantly being made. There are more new ones than we've even talked about today that there's just not enough data on to know much about at this point. So the workup is pretty standard. Again, most of this is going to be done in the emergency department, but it is important for people to know. There are some of us who are going to be going into general pediatrics who may be practicing in a hospital that's not a children's hospital, and we don't necessarily have the pediatric pharmacist available, we don't have the pediatric respiratory therapist available, and so you're going to need to know how to see these kids and assess them and start sort of the workup. So know the antidotes and keep the airway in mind is always key. Make it a habit to call poison control. Again, it's not only for guidance and for support for the physician, because these are potentially scary situations, but it does help to keep track of the data regionally for us. And then for our outpatient setting, anticipatory guidance is the key, both for the patient and the resident, and the parent, but also realize that sometimes the family situation actually enables the problem. So it's important to know when to get other professionals involved, whether that be DCS, counselors, law enforcement, any variety of things. So it's important to realize that there are limits as far as that goes. Now in our own clinic, we do have behavioral health specialists, so it is nice because we can kind of grab them if we get a red flag on that screening questionnaire and kind of try to attack it before it really becomes a problem, but not all offices do that. So it's important for the physicians to realize this as well. And those are my references. Anybody have any questions? Thank you.
As you all are thinking, if you have a couple of questions, thank you for a wonderful talk.
You're welcome.
Jaynes. I want to remind this is really information that we all need and we see day in and day out, and there were lots of new things I learned, especially about ingestions, of the synthetic ingestions. I want to remind everyone to complete your evaluations, please, because that's how we get accredited for grand rounds. We are actually winding down this year's grand rounds and coming towards the end of this season. We have one in June. We usually don't do the last week of June because most of us are graduating and we have new folks coming in, so we wind down after the next time, which will be, I think, on the 9th of June. Dr. Bull will be presenting for us. In the fall, we plan to move our Grand Rounds dates to a Wednesday. So please take note of this. It's going to be on the 2nd and 4th Wednesdays of the month. Also, our rising third years, if you want to get ahead and really plan ahead, I have the Grand Rounds list of dates here. We've already had a few people sign on. I think it's come to us electronically as faculty, and I would love for any of the faculty that are here too to sign on. So I'm going to leave this at the CME desk. If you want to look at the dates, and if you already know when you would like to present, do go ahead and sign on. And then we'll send it to you electronically also. But thank you again, Dr. Jaynes.
You're welcome.